Hello, friends. Imagine rushing to the emergency room with a severe illness. You spend 4 days and 4 nights in a hospital bed. The doctor says you are stable, but you need to go to a skilled nursing rehab facility for 3 weeks to regain your strength. You assume Medicare will cover it because you were in the hospital for 4 days. But 3 weeks later, the nursing home hands you a bill for $12,000. Why? Because of a hidden hospital billing trick called observation status. The hospital never officially admitted you as an inpatient, meaning you completely failed the strict Medicare 3-day rule. You were treated like an outpatient while sleeping in a hospital bed, and now Medicare is legally refusing to pay a single dime of your rehab. I want to be perfectly clear right from the start. This isn't a scam run by doctors or a conspiracy to steal your money. This is the official Medicare Part A billing law regarding skilled nursing facilities, and you must understand how to navigate it to protect your life savings. By the end of this video, you will understand the devastating financial difference between being admitted and being placed under observation, the exact federal MOON form you must watch out for, and the step-by-step appeals process to force Medicare to cover your $10,000 rehab stay. I'm also going to reveal the self-administered drug trap, a completely separate billing nightmare where the hospital pharmacy can charge you full retail price for your daily blood pressure pills while you are sitting in that observation bed. Rules change every single year, and the government never sends a letter to explain your choices. Subscribers to this channel find out about these structural traps in time to protect their accounts, while the others only find out after their money is gone. Hit that subscribe button right now so you never get left behind. Let's look at how the clock actually ticks when you cross the hospital threshold. Medicare Part A will pay 100% of the cost for the first 20 days of a skilled nursing facility rehab stay, but only if you meet a strict prerequisite. You must have a medically necessary, formally admitted inpatient hospital stay of at least 3 consecutive days. This is the bedrock of the law, but the way Medicare defines a day is not the way you and I define a day. To protect your savings, you have to understand the 3 midnight mandate. First, understand that 3 days actually means 3 consecutive midnights. If you are in a hospital bed at 12 midnight, that counts as 1 night. Second, the midnight of the day you are discharged from the hospital does not count toward your total. Third, any time you spend in the emergency room before a doctor signs the paperwork to formally admit you does not count. Because of this, you need to track your midnights strictly on a piece of paper the moment you are moved to a room. Do not rely on the hospital's verbal reassurance. Write down the day, the time, and whether you were there when the clock struck 12. Let me show you how this plays out for a real person named John, who is 72 years old. John goes to the emergency room on Tuesday night at 8 p.m. Because he is having severe trouble breathing, the ER doctors stabilize him, run tests, and keep him in an ER bed overnight. On Wednesday morning at 10, a physician formally admits John to the hospital as an inpatient and moves him to a regular floor. John stays in that room, recovering until Friday afternoon at 2 p.m. when the doctor discharges him directly to a rehabilitation facility to regain his strength. Let's do the actual dollar math on John's stay. John spent Tuesday night in the emergency room. Because he was not formally admitted yet, Tuesday night does not count. He spent Wednesday night admitted in his hospital bed as an admitted inpatient. That is 1 midnight. He spent Thursday night at midnight in his bed as an admitted inpatient. That is 2 midnights. On Friday at 2 p.m. he leaves. Because the day of discharge never counts. Friday night is 0. John spent a total of 4 days in a hospital building, but he only accumulated 2 official midnights under Medicare's rules. He failed the 3-day rule. Medicare Part A will pay exactly $0 for his subsequent rehab stay. At an average out-of-pocket cost of roughly $400 a day, a 20-day rehab stay will cost John $8,000 out of his own checking account. Now look at the situation variation. If John's family had tracked the midnights on paper and realized they were short, they could have spoken to the doctor. If John had simply stayed in that hospital bed until Saturday afternoon, instead of leaving on Friday, he would have hit his 3rd midnight on Friday night. That 1 extra night in the hospital bed would have activated his Medicare Part A benefits, covering 100% of the first 20 days of rehab. That single extra midnight is the literal difference between paying $0 and losing $8,000. But counting your midnights doesn't matter at all if the hospital secretly categorizes your bed the wrong way behind your back. This brings us to the observation status trap, which switches your entire hospital bill over to Medicare Part B outpatient billing. You can sleep in a hospital bed, wear a hospital gown, eat hospital food, and have nurses check your vitals every hour for 5 straight days. But if the doctor classifies your stay as being under observation status, you are legally considered an outpatient. The clock never starts ticking for your rehab benefit because observation time is billed to Medicare Part B, and Part B absolutely never pays for nursing home rehab. To keep from falling into this category, you must follow a strict 3-step action plan. First, do not assume that because you have been wheeled out of the emergency room and into a private room that you are an admitted inpatient. Second, look the attending physician or the charge nurse in the eye and ask the magic question, am I officially admitted as an inpatient or am I here under observation? Third, you must ask this exact question every single day you are in that bed. The hospital has an internal billing review board that can review charts and change your status backward from inpatient to observation without telling you. Consider Susan, who is 68 years old. Susan slips on an icy sidewalk and hurts her hip. She is brought to the hospital, put in a room, and stays there for 4 consecutive midnights while the medical team runs specialized scans and consults with orthopedic specialists. The doctor then determines she doesn't need surgery but needs 15 days of intensive physical therapy at a local skilled nursing facility. Because the hospital classified Susan under observation status the entire time, she was an outpatient every single night. She failed the 3-day inpatient rule. The nursing home accepts her for admission, but they send the bill directly to her. At $400 a day for 15 days, Susan owes $6,000 out of pocket. To make matters worse, because her entire hospital stay was processed under Part B instead of Part A, she is responsible for the 20% Part B coinsurance for every single x-ray, blood draw, and doctor visit during those 4 days, adding thousands of dollars of unexpected medical debt to her name. Here is how the situation changes depending on your coverage. If Susan has a private Medigap Plan G, that supplemental policy will step in and cover the 20% Part B coinsurance for the hospital tests, saving her from that specific doctor bill. But Medigap will not pay a single dime of the $6,000 nursing home rehab bill. A supplemental policy is designed to only pay when Medicare approves the primary claim. Since Medicare rejected the rehab claim because of the observation status, the supplemental policy legally walks away, leaving Susan completely on the hook for the full balance. To prevent seniors from being completely blindsided by these bills, the federal government now forces hospitals to hand you a very specific warning document. That document is called the Medicare Outpatient Observation Notice, or the MOON form for short. Under the Federal Notice Act, hospitals are legally required to give you this written notice if you receive observation services as an outpatient for more than 24 hours. This isn't just an informational brochure. It is an explicit, high-stakes warning printed on federal paperwork. It tells you directly that you are an outpatient, that your time in the bed does not count toward the 3 midnight rule, and that your upcoming rehab stay will not be covered by Medicare Part A. You and your family must know exactly how to handle this form when it crosses your table. First, you need to watch the paperwork that you or your adult children are asked to sign on the second day of your hospital stay. Second, if they hand you the MOON form, do not treat it like standard check-in paperwork. Read every word carefully. Third, do not just sign it, hand it back to the clerk, and hope for the best. Demand to speak with the hospital's social worker or the lead discharge planner immediately. Fourth, tell them directly, I will need skilled nursing rehab when I leave, and I cannot afford it if I am kept under observation status. I need the attending doctor to review my medical chart right now for a full inpatient admission. Let's look at what happened to Robert. Robert is recovering from a severe infection, and while he is asleep in his hospital bed, his adult daughter sits by his side. A hospital representative walks into the room with a clipboard and asks her to sign a stack of standard administrative documents. She signs them quickly so her father can rest, unknowingly signing the MOON form. 4 days later, Robert is discharged, and his daughter tries to transfer him to a local rehab center. They are shocked when the admissions office at the facility demands a $5,000 deposit upfront before they will even give him a bed. Because the hospital legally provided the MOON form, they are completely protected from liability. The federal government considers Robert fully notified. He is now entirely responsible for that $5,000 upfront deposit, plus the $400 a day ongoing fee for the rest of his care. If his daughter had caught that specific form on day 2, they could have stopped the process, called the doctor into the room, and fought for an inpatient admission before the final discharge orders were written. Understanding the variation in how you sign this form can save your case. Signing the MOON form does not mean you agree with the hospital's decision. It simply proves that the hospital handed you the notice. If you are forced to sign it to keep your care moving, you can physically write the words, "I disagree with this outpatient status," right next to your signature. Doing this creates an immediate, undeniable paper trail that you can use to protect yourself during a later appeal. So how do you actually force a doctor to change your status from observation to a full inpatient admission? You use the federal government's own strict time limit against them. This is where the 2 midnight rule comes into play. The Centers for Medicare and Medicaid Services, or CMS, established this rule to clear up billing confusion. The law states that if the admitting physician expects your medical care to require a hospital stay that crosses at least 2 midnights, the doctor generally should formally admit you as an inpatient right from the beginning. It shifts the burden onto the hospital to justify why they are keeping a sick senior as an outpatient if they know they are staying for multiple nights. When you find yourself stuck in a hospital bed, you must use this rule in a precise 4-step conversation. First, if you are still listed under observation status on day 2 of your stay, respectfully confront the attending doctor during morning rounds. Second, use the exact legal phrasing and say, "Under Medicare's 2 midnight rule, I require hospital-level care that is clearly going to cross a second midnight, so I need you to write the order to formally admit me as an inpatient." Third, do not leave it at a verbal agreement. Ensure the doctor physically inputs the words "admit to inpatient" into your electronic medical chart before they leave your room. Fourth, verify with the charge nurse at the station later that afternoon that the internal billing code has officially been flipped. Consider David, who is 71 years old and is brought to the hospital with severe pneumonia. He spends Friday night in a room under observation status. On Saturday morning, the attending physician reviews his lab work and tells David that his infection is stubborn, meaning he will need to stay on continuous intravenous antibiotics until at least Monday morning. David's son is sitting in the room and immediately invokes the 2 midnight rule. He explains to the doctor that since the medical care requires David to stay through both Saturday and Sunday night, he must be admitted. The doctor agrees and writes the formal inpatient admission order on Saturday. David hits his midnights on Saturday night, Sunday night, and Monday night as an officially admitted inpatient. He hits his 3 mandatory midnights perfectly. When he is transferred to rehab on Monday afternoon, Medicare Part A covers the first 20 days at 100%. David saves $8,000 to $10,000 simply because his son knew the exact CMS phrasing to use with the doctor. But you must stay alert because a hospital status can change at any moment. Hospital billing departments routinely review charts behind the scenes. Even if a doctor admits you, the billing board can overrule them and flip your status back to observation before you leave to avoid a potential Medicare audit. You must remain completely vigilant about your status up until the exact hour you are discharged. Now, there is one massive group of seniors who can completely ignore this 3-day midnight rule, but it comes with a dangerous financial trade-off. If you are enrolled in a private Medicare Advantage plan, also known as Medicare Part C, instead of original Medicare, you operate under an entirely different set of rules. Private insurance companies are legally allowed to waive the 3-day prior inpatient hospital requirement completely. Many Medicare Advantage plans will approve a stay in a skilled nursing rehab facility, even if you are only in the hospital emergency room for a single day, or in some cases, without you ever stepping foot inside a hospital at all. To navigate this benefit safely, you must follow these 4 steps. First, pull out your specific Medicare Advantage evidence of coverage booklet, which is the thick legal document sent to you each year. Second, look directly for the section labeled Skilled Nursing Facility Care. Third, verify if your specific plan explicitly waives the 3-day prior hospitalization rule for network facilities. Fourth, do not assume this means you can choose any rehab center you want. You must verify their network restrictions. Take the example of Linda, who has an Aetna Medicare Advantage plan. She falls at home, hurts her knee, and spends just 12 hours in the emergency room getting checked out. Her doctor recommends 2 weeks of rehabilitation. Because her private plan utilizes a Part C waiver, she bypasses the strict 3-day Part A inpatient rule completely and goes straight to a rehab center the next morning. Let's look at the dollar math for Linda. She avoided the hospital stay, but her Medicare Advantage plan charges a flat $180 daily copay starting on day 1 for a skilled nursing stay. Original Medicare charges $0 for the first 20 days. At $180 a day for 20 days, Linda must pay $3,600 out of her own pocket. She got into the facility much easier than someone on original Medicare, but she pays significantly more in daily out-of-pocket costs for those first 3 weeks. There is another massive situational variation here, your freedom of choice. If you are on original Medicare, you have the legal right to use your benefit at any of the 15,000 plus Medicare certified nursing homes in the United States. A Medicare Advantage plan, however, strictly forces you to use their private contracted network of facilities. If the only approved rehab centers in your plan's network have terrible quality reviews, or if they are located 40 miles away from your family, you are completely trapped using them anyway. If you are fighting to get admitted on original Medicare, there is one final legal lifeline you can pull right before the hospital tries to discharge you. That legal lifeline is called a QIO Fast-Track Appeal, and it is handled by an independent organization known as a Quality Improvement Organization. These organizations are groups of independent doctors and medical experts hired by the federal government to review hospital decisions. If you are on original Medicare and the hospital tries to discharge you to a nursing home while leaving you under observation status, you have a legal right to stop the clock. The moment you file this expedited appeal, the hospital is legally forbidden from discharging you while the independent doctors review your records. To pull this lifeline, you must act immediately. First, the moment the hospital hands you your official discharge paperwork, look at the back of the page for the name and phone number of your state's designated QIO, which is usually a company called Levanta or Kepro. Second, call that phone number immediately. These hotlines operate 24 hours a day, 7 days a week. Third, tell the representative exactly these words: I am filing an expedited fast-track appeal regarding my discharge and my outpatient observation status. Fourth, wait in your room while the QIO contacts the hospital within 24 hours to independently seize and review your medical files. Let's look at how this saved Mary, who is 75 years old. Mary is told by her hospital team that she is being discharged to a rehab facility the next morning, but her chart still lists her under outpatient observation status. Instead of packing her bags, Mary's family calls the QIO hotline at 8 o'clock in the morning to lodge a formal fast-track appeal. Let's look at the dollar math. The moment Mary's family makes that phone call, the hospital is forced to stop the discharge process. They must keep Mary in her hospital bed at no extra charge to her while the QIO conducts its investigation. Within 24 hours, the independent QIO medical board reviews her files and rules that Mary's severe medical condition required a full, formal inpatient admission from day 1. The QIO forces the hospital to retroactively change her billing code. Because of that change, Mary hits her 3 midnight mandate perfectly. Her $10,000 skilled nursing rehab bill is successfully pushed onto Medicare Part A, and Mary pays exactly $0 for her first 20 days of recovery. You must, however, understand the risk if the appeal fails. If the QIO reviews your records and ultimately agrees with the hospital's decision, you will be held financially responsible for any extra time you spent sleeping in that hospital bed after noon of the day following the QIO's final decision. It is a calculated risk, but it is often the only legal tool you have left to force a billing correction. Finally, even if you never have to step foot inside a skilled nursing rehab facility, being held under observation status exposes you to one of the most predatory hidden billing traps in the entire American healthcare system. This is the self-administered drug trap, and it deals directly with Medicare Part B routine medication billing. When a doctor formally admits you to the hospital as an inpatient, Medicare Part A covers everything under a flat rate: your room, your meals, your procedures, and every single pill the nurses hand you. But the moment you are classified under observation status, you are an outpatient. Under Part B outpatient rules, Medicare does not cover self-administered drugs. That is the official government term for the routine daily medications you already take at home for chronic conditions like blood pressure, high cholesterol, or diabetes. The hospital pharmacy will still dispense these pills to you because you are in their building, but they will bill you at full, hyper-inflated hospital retail prices. To avoid this pharmacy debt, you must follow a strict 4-step action plan the moment you find out you are under observation. First, tell your attending nurse immediately, "I want to take my own home medications." Second, have your spouse, your adult child, or a friend immediately go to your house, gather your actual prescription pill bottles from your bathroom cabinet, and bring them directly to your hospital room. Third, demand that the hospital physician physically write an official order in your chart approving you to take your own brought from home medications. Fourth, explicitly refuse to let the hospital pharmacy dispense or open any of their own supplies for your routine daily pills. Let's look at how this bit, Richard. Richard takes a daily branded blood thinner and a specialized maintenance inhaler for his lungs. He is held in a hospital bed under observation status for 3 days. He leaves his medications at home in his cabinet and simply lets the floor nurses hand him the hospital's pharmacy supply during his stay. When the bill arrives, the math is staggering. The hospital pharmacy charged Richard $50 for every single daily blood thinner pill and a flat $300 for the single inhaler they opened for him. Richard is hit with a massive $600 bill just for 3 days of his routine medications. He submits it to insurance, but Medicare Part B denies the claim entirely because it was for self-administered drugs. He tries to send it to his private Medicare Part D prescription drug plan, but Part D denies it because the hospital pharmacy is considered an out-of-network pharmacy. Richard has to pay the entire $600 completely out of his own pocket. If he had simply had his family bring his $10 copay bottles from home, he would have saved $600 instantly. You must prepare for a situational variation at the nursing station. Some strict hospitals have internal safety policies that completely forbid patients from taking any medication brought from outside the building. If they force you to use their pharmacy while you are held under observation, you must ask the hospital billing department for a fully itemized receipt the day you leave. You can then submit a manual paper claim to your Part D plan to fight for a partial reimbursement, though the process is notoriously difficult and rarely pays back the full retail amount. Let's review everything we have uncovered today so you can protect your savings. First, the 3 midnight mandate requires 3 consecutive midnights as a formally admitted inpatient before Medicare Part A will pay a single dime for your rehab stay. Second, observation status means you are legally an outpatient in a hospital bed, leaving you completely exposed to an $8,000 rehab bill. Third, you must watch for the mandatory federal MOON form on day 2 and immediately demand a social worker if you see it. Fourth, use the CMS 2 midnight rule to explicitly demand that your doctor change your status to inpatient if you are staying multiple nights. Fifth, remember that while a Medicare Advantage plan can waive the 3-day rule, they will charge you heavy daily copays and lock you into a restrictive network of facilities. Sixth, use your legal right to a QIO Fast-Track Appeal to freeze a wrongful discharge and force an independent medical review. Finally, never fall into the self-administered drug trap. Bring your own routine pills from home so the hospital pharmacy cannot bill you hundreds of dollars for a single dose. A hospital bed does not guarantee Medicare coverage. You must fiercely advocate for your formal admission status, because counting to 3 midnights is the only mathematical way to protect your life savings from a devastating nursing home bill.